Hello, good evening, everyone. Welcome to my IVF Answers and the European Fertility Society. Thank you so much for joining us today. I know that you've been waiting for us a bit, but thank you for joining. And I know you have been impatient a bit, but we are here. Please just confirm for us that you can hear us loud and clear. As you can see, I'm with Dr. José Félix García already. Hello, Dr. García. Welcome to my IVF Answers. Welcome back. This is not your first webinar with us. I'm glad that you are joining us today. And we are going to explore this interesting topic. We've discussed PGT-A a lot for sure this year. However, non-invasive PGT-A is still something new. I'm glad we are going to discuss it today. How have you been? Hope you are ready to educate us today a bit more.
Well, we'll see. I hope that we will have a good time here together and not very long. I don't want to pretend to be very long. Just precise and wait for the questions and sorted all these doubts.
Definitely. Thank you so much indeed.
Thank you.
So remember, we will start with Dr. José's presentation, and then there will be time for your questions. So you can put those questions in the chat. You can either start typing them now, or you can save this for later. This is all anonymous as well, so don't hesitate. If there's anything you wish to learn more about non-invasive PGT-A, this is your time. This is something that we definitely are looking forward to. Let me just say that Dr. José Félix is the medical director of URL Ángel, and he's located in Malaga. Am I right?
Yeah, that's right.
Okay, good to hear that. Then thank you for confirmation, and I believe we can go ahead with our presentation. Thank you so much for joining.
Hello, good evening, everybody. And well, just in a few minutes we're going to start. I want to say first that yes, I know that we have talked about a lot about the invasive PGT-A, but I'm going to touch that subject just for a few minutes because it's very difficult. First, because I don't know how many people has been attending these speeches before, so I don't know who is the audience, etc., and if they know very well what invasive PGT-A. I'm not going to be a long time with a invasive PGT-A, but just enough to understand the second part, which is the non-invasive one. So the speech is divided in two parts. Yes, at the beginning as a way for introduction, talking about a little bit about PGT-A, and then immediately after, then we clarify what non-invasive PGT-A is and the difference and the indications. Right, so first of all, if we talk about non-invasive or invasive PGT-A, we need to know what chromosomes are and what a karyotype is. So here we've got euploids, embryos or people, which is have normal chromosomes. For example, this is here a male. You know that we have 22 chromosomes per chromosomes plus the chromosome X and Y. This is a normal male, and this is a normal female with 22 pairs plus the sexual chromosomes X and X. But here, then we find that this is an aneuploid embryo, for example, which is a Down syndrome. As you can see in number 23, this is not a pair. There are not 2 chromosomes, but 3. I have to say that now in a few image, then we're going to see that we don't represent, when we study the genetic professionals, the genetists look at the embryos, they are not going to see the chromosomes in this way, but in another different way that we will see that in a minute. Right. Here, then, historically, that we may being studied the embryos in a different way. Well, in the number 2 is as we used to do the invasive one time ago, years ago. It was not very accurate because we will did the biopsy, at a stage of 8 cells, and we could obtain only 1 cell because if not, if we obtained more cells, the embryo could die. So just 1 cell was not representative of the embryo. So nowadays we do the biopsy, the invasive one, we're talking about now the invasive one, up on the trophoblast, on the embryo, on day 6, day 5, where there are many cells, and we can obtain a good group of 6-7 cells, and then the diagnosis will be more accurate. Then here, these cells that we have obtained, then they are processed in the lab, and then finally, this is what we obtained. Here we got 3 examples. This is what we're going to see on both cases, in invasive PGTA and in non-invasive. Take this picture in mind. In the first one, we see a line here, and then it's very small, but here is chromosome number 1, and 1, 2, 3, 4, 5, etc., till chromosome 22, and the X and Y. And this is a normal, it's an euploid embryo. When they see that, they say, okay, we can transfer this embryo because it's normal. You see that all chromosomes in line are in the same level, except the Y, which is smaller and has less weight and comes down a little bit more. But here, the number 2 and number 3 in red, they are aneuploid. They are not normal. And you can see here, which is a defect in chromosomes in the pair 22, or here in the third one, where we see problems in the chromosome 15, in the pair 15, and here in the chromosome X as well. Okay, so there are in the sex chromosomes, we've got a problem here and a problem as well in number 15. So these 2 embryos should be discarded and not be transferred. So far, this is the invasive PGTA. What are the indications? So advanced maternal age, because the older the woman, we know that the worse the quality of the eggs, they come with more chromosomal alterations, and they want to know which one is normal, because the probability of having a miscarriage or their abnormalities are high. When we have that patient has more than 2 miscarriages or failure of implantation, in that case, then they demand, we want to know if the cause of these miscarriages or failure of implantation is the embryo itself, and because it comes with abnormal chromosomes. And finally, when there is a male problem, and it's the male who is contributing with spermatozoids with abnormal spermatozoids because of a fish or fragmentation of DNA alteration of that test. Right. So far, this is the invasive one. And here, then we see how good it is, because in the yellow one, we see how, as time passes by, then the probability of a pregnancy comes down in women who haven't done a PGS or PGT-A, different names. But if a woman of 42 or more than 42 has done a PGT-A, a biopsy of the embryo, and she has a normal embryo, the possibility of pregnancy, the possibility is exactly the same as if she were 25. So the factor of age has been completely forgotten, has been solved, and this is PGT-A, means that we have almost 100% certainty, we are sure that that embryo is healthy and we can transfer it with all guarantees. So now we go into the subject, non-invasive screening. How is that? Well, we don't touch the embryo. Here we see in day 6, day 5, the blastocyst, and the blastocyst has been growing in culture, in a medium culture, and then what the biologist is going to get is just that medium culture where the embryo has released some DNA of their cells. And then these are collected in a next generation sequencing, and then we have the report. The report will be the same as this one. Look, I'm going backwards. this is what in a non-invasive PGTA, the genetist is going to see exactly the same. Then why we are not using non-invasive PGTA all the time, right? So the reason is, well, I'd like to talk about these three concepts: lab validation, algorithm, and 85% concordance. This is the keyword, probably. So let's say that before going ahead, any lab, any reproduction unit with a non-invasive PGTA, it has to be validated. It means that the genetic lab must be certain, but be sure that reproduction unit is doing things well. They know how to do it. It's a very simple procedure. On the contrary, doing the biopsy of the embryo needs to have a quite expertise, and has to come the genetist with the laser and make a little hole in the embryo. Here is quite simple, and any biologist can do it. She has to be very well protected for not contaminating that medium with her cells or their cells. And then this is what we see. So first, validation. Now we are doing in our clinic non-invasive PGTA, but before doing that, we had to choose those cases where a particular patient was going to do an invasive one. So we sent the genetist came here. He did the biopsy, and at the same time, our biologist got a sample of medium, and then in the lab they have to compare and see if there were coincidences in between what the invasive PGTA was saying and the result of the non-invasive one. Then here we've got that there is a normal one in PGTA, and an euploid as well was a coincidence. Here in this one, a coincidence again, and here there was a defect in chromosome X and was detected by both of them. And later we will talk about this algorithm, okay? And finally, a third case where this embryo is not going to be transferred, as you can see, the previous one, sorry, I'm going to come back here. This particular one has a probability of a 40% of being euploid. There is an algorithm, there is a artificial intelligence is coming into subject, and they may say that this embryo can be transferred because they can see that by these results that not all cells are bad, are aneuploid, and the embryo may change as is growing and dividing the cells, may eliminate the bad ones and just to carry on with the good ones. But it says that probably the percentage of euploidia of being euploid is a 40%. But here, in this case, it's a 0%. There's no way this embryo is not going to be transferred following the PGTA, the invasive one. And there is again a coincidence in between two. So before going ahead with that, we have to show our genetic department that there were some sort of coincidence. So hold on, sorry. Right. So let's come back to this one. Here, the key word and the problem is that as if we do an invasive PGTA, we have a 99.9% of certainty that that embryo is healthy, is euploid. Here, with the non-invasive one, because of different problems of contamination, or technically, or because there is not enough DNA, whatever, then there is not 100% coincidence. If that were so, then we will forget. We would have forgotten the non-invasive, the invasive one, and now we will work with non-invasive from now on. But it's not as accurate as the invasive one. So there is and 80%, 85% of the cases, the non-invasive one say exactly the same thing as the invasive one. So that's why we cannot consider both tests in the same level. We cannot consider it as a diagnostic test nowadays, but as a biological marker. So, because of that, who can get benefit from this non-invasive biopsies with this non-invasive PGT-A? For example, couples without indication of PGT-A. As we said before, if a patient comes here with a lot of miscarriages and they want to know if it's an embryo cause, then we cannot, we should do the invasive one. Indications as well, patients with good prognosis couple, above all, those with a very high number of eggs. Because in the end, this biological marker, this non-invasive one, as it's giving us an 80% of concordance, is going to tell us which embryo is coming first, which is coming second, etc. The genetic lab cannot assure that this embryo is, they can see that line with the chromosomes, but they cannot sign and say, okay, this is 100% sure that this is an euploid embryo. They cannot say that. They can be more or less sure that that particular embryo is good or not. So the information will be the number one has a probability of being euploid in more than 85%. Fine, that will be the first one we're going to transfer. The second one has more than 40%. Okay, so that will come in second place, depending on the number. Other chromosomes, for example, if they see, and so on, I mean, they will give us a percentage. So more than 85, 70%, 40%, 20%, or sometimes they will say, we cannot transfer that embryo because we have seen that the defect is in a chromosome that is compatible with life. Let's say in chromosome 21, we have seen that there is a defect and that embryo, particular embryo, the number 6, can be a Down syndrome. So we cannot take the risk. If you want to be sure and to transfer that embryo, you should have an invasive PGTA to be completely sure. All right? So, but for example, another one, the number 7, may have a 20% only probability of being euploid, but they have seen the defect in a chromosome number 17, which is incompatible with life. So there are two options, a 20% of eliminate the bad ones and going ahead, fine, or not. In that case, will be a negative pregnancy test or miscarriage, but never an alive baby with a problem. So these non-invasive tests, they may see where the problem is. Thanks to an algorithm where the intelligent artificial intelligence is coming into place, it's going to tell us a percentage of euploidia, of being euploid, and consequently, the woman will get the benefit of transferring the best ones, right? And also to know that one particular or two particular embryos shouldn't be transferred because that percentage of euploidia is just playing with a very dangerous chromosome, which may give a Down syndrome, let's say, or Edwards syndrome, or Turner, or whatever. So then, this is that we prioritize the transference. As we said, it's a biomarker that allows us to obtain information about the embryo chromosomes. Group 1, as we said, probability of more than 85 of being euploid. Group 2, embryos with chromosome alteration, segmental or mosaicism, that probability of 40% of being euploid, and they can be transferred. Or other embryos which are very bad with a very low probability. The equivalence nowadays will be, this is an embryo type A, this could be an embryo type C or BC, and this is an embryo D. All of us know that sometimes an embryo with that the biologists qualify as D may give a pregnancy, but we cannot compare with an embryo type A, which gives a very high percentage of pregnancy, right? So it's another way to classify, more accurate, because it's based on chromosomes, to classify the embryos. That is as the technique allows us to work, right? So the difference, as I said, is this is just a biological marker. It puts in order, and the benefit is that the woman has more chances of getting pregnant sooner, because we know which is the best, with the best, more probabilities, the best one. And then what I told you, what happened if they detect that the alteration is in chromosomes 21, which is a Down syndrome, 13, which is Pato or Edward, or problems with chromosome X, that then we have to be sure, completely sure, and recommend the invasive PGTA. And just the last one, the conclusions. The non-invasive PGTA is a system to prioritize upon the chromosomes detected in the media culture. Its concordance with the very accurate invasive one is an 85%. At the moment, we cannot consider this non-invasive PGTA as a diagnostic method. The non-invasive PGTA is the best method of non-invasive embryo selection, as it is the only one studying the number of chromosomes. But neither the invasive one or the non-invasive one increases the accumulated rate of pregnancy, but allow to obtain the pregnancy early to avoid unnecessary transference. One and the other is going to tell us which one is the best. So, but if the woman doesn't do this test and she has 3 or 4 embryos, and there is one, let's say the third one is euploid, she will get the pregnant at the third attempt. While if she does these sort of things, then with the first one, with the invasive one, she will eliminate 2 transferences, for example, and she will have the opportunity to get pregnant earlier, as it happens with the non-invasive one. So now I'm open to all questions. I hope that I didn't want to be very long, and I hope that I was clear enough to make you to understand this subject. Here I am if you have any doubts, any questions.
Definitely an interesting presentation. Thank you so much for talking about this topic today, for sure. And now, yes, it is time for all the questions. And as you can see, there are some questions ready. So let's get to those. I'm sure it's going to be an interesting session. This is definitely an interesting and still new topic. So let's see the first question we have from Dory. So what are the dangers of the invasive version of PGTA? How often do complications occur with invasive PGTA?
Well, obviously the danger of invasive variant is that we may damage the embryo. I have to say that happens very, very rare, okay? But obviously, as we touch the embryo and we take some cells out, some embryos may die, we may say, okay? But there's a principle in medicine, never not to have to cause harm, damage. So if the technique were very bad, then we wouldn't do it. But sometimes the embryo may get some damage at the time of doing it. How often that complication occurs? I don't have the figures, but not very, very often. If I say more, I've obtained more problems with the invasive one. Having done the biopsy, the embryo survived, but then the lab give us a report, we say that they didn't get any conclusion because they were not, the cells that they obtained didn't divide properly, or the chromosomes, and we have embryo without a diagnosis. So we say we have studied 4 embryos. Number 1 is euploid, number 2 and 3 aneuploid, and number 4 no diagnosis. We don't know. So that is what happened more often. And I suppose that problem may occur exactly the same with the non-invasive one, which is a technical problem in the lab. And they couldn't see the chromosomes in that line that we saw before, right?
All right, makes perfect sense. Again, thank you so much. I do believe it helped already. And let's have a look. Another question from Dori. How does the karyotype test help to rule out aneuploid?
How does the karyotype
embryo
test to rule out an aneuploid embryo? Right. You mean I assume that the karyotype, well, because what we studied with the invasive and with the non-invasive one is the karyotype of the embryo. Karyotype means to check the 46 chromosomes, the 22 pairs plus the sexual one. So it goes with the definition. I mean, as the invasive one and the non-invasive one are looking into the karyotype, if that line that we saw, it shows the karyotype in a line, there is a defect, as we saw, that the number 22 is not in the line. I'm not going to come into technical details, but it's up or down the line. It means that that karyotype is normal, and an abnormal karyotype means aneuploid. And depend the chromosomes where that line is disrupted, then if it's up on the number 13, they say, be careful, this might be a Pateau syndrome. Don't transfer it. All right. Or this is up on the chromosome 17, as we said. Well, there is no alive people with a defect on the 17. This may finish in a miscarriage or negative pregnancy test, or maybe if that defect is not very big, then it may be a healthy baby if in the future is going to eliminate the bad ones. But that is a work for geneticists, not for a gynecologist, all right? But aneuploid and karyotype is, the karyotype is telling us if it's a normal karyotype is euploid, and an abnormal one is aneuploid. And we look at the karyotype in the embryos. In one model way.
Yeah, and I will actually go to the next question from Dory. I will go back to the previous question. So PGT-A, that can it detect 99% a trisomy 21? I was told embryo could look, even checked with PGT-A perfect, but could have a trisomy 21 anyway. So is this true?
Let me read this carefully. Does PGT-A 99% detect a trisomy 21? I was told that an embryo could look even checked with PGT-A perfect. Right. Well, yes. When the geneticists give us the report, and nowadays with all the demands and to suit doctors, etc., they say, well, this technique is almost perfect. It's a 99%, but because there is a 0.1 probability of having a mistake, then they say, okay, we have to transfer this, but once you are pregnant, we advise you to have the non-invasive prenatal test or amniocentesis or whatever you need. Well, not amniocentesis, nowadays we don't do that. The non-invasive prenatal test to be absolutely sure, because there is a 0.1 and that is enough. And we don't want in our life of a professional to have a demand, because we have done 1,000 and there was just one that fails, and we said that was euploid and was aneuploid. It's extremely rare, but they always say that because of that 0.1, 0.2, then we recommend, once you are pregnant, to check that the baby is coming. You may be tranquil, you may be sure it's going to be all right, but we say that to protect ourselves or the genetist. Okay.
Okay, thank you so much, Dory, for your questions. If you have anything else, you know what to do. And let me go to the previous question. So is it already possible for the patients to choose between PGTA and non-invasive PGTA, and how is it evaluated?
Of course, that is the question, the discussion that we have with the patient. We advise the patient, what is your problem? Do you have repeated miscarriages? So we are going to advise you to have an invasive one. That indication that we say, we have to show the patient that. Then are you young? And then you have, in the end, after IVF, you have 6 blastocysts. Then I advise to have the non-invasive one. Why? Because maybe of these 6 blastocysts, probably she's going to have 2 euploids. And then you say, well, non-invasive one, I don't put the embryo at risk as much as I do with the invasive one. It's more expensive, the invasive one. The non-invasive one is cheaper. It's more economical because we don't need the genetics, the laser, nothing. It's easier. And then I'm going to have an order in those embryos, and the probability of getting pregnant sooner is higher than if I don't do it. So depending on the cases, we have to tailor the suit properly, depending on the cases. So that is a discussion, and we have to, this short presentation, more or less, or shorter, we have to explain to all patients in order to know what to choose. At the end, they will decide, obviously, but under our advice.
Sorry, there is like a similar question again here, because can you provide real-life patient stories on testimonials who have undergone non-invasive PGTA, highlighting their any challenges that they have faced throughout the process.
Can you provide real-life patient story testimonial? No. Any challenge? I don't understand. Sorry, exactly.
Any real-life patient stories who have done non-invasive PGTA? Any challenges they have faced?
No.
Or Elisa, if you can explain what you mean exactly. But any real-life patient stories about when someone used non-invasive PGTA?
Well, of course, I've got patients that have done it. I mean, examples of patients who have done it. Yes, of course. Yes. Nowadays, we offer the non-invasive PGTA. It's something that we advise to all people because it's the best way to classify the embryo. So we talk about that to all our patients. Then they will decide to do it or not. But in the real life, we're doing this. We propose this to do it every day. And then a percentage of patients are going to do it. Why? Because Steph is going to change, to substitute that, may say, all classifications of A, B, C, A, B, etc. on the embryos based on morphology. And this is a better approach. So if you want a better approach and to get pregnant sooner, do this instead of letting the biologist to see that this is a very nice embryo. It's an A1. And then the A1 is not giving the pregnancy and the BC is giving the pregnancy. This will change the order. I may say that BC, which was the 4th in the queue, the 4th in the order of embryo, is going to be the first one now, because we've seen that there's an 85% chances of being euploid. So that is when it's going to change. So we have to show the patient to understand, and they say, okay, I prefer to spend some more money in analyzing this in this way rather than in the other way. And this is the everyday work. Yeah.
Okay, thank you. Thank you, Lisa. If there's anything else you wish to add, of course, you know what to do. And let's have a look at this question. So thank you for your presentation.
Thank you.
Please, what's your experience with the transfer of mosaic embryos?
Fine. I'm very tranquil about that because I'm not going to decide what we're going to transfer. Is the genetist. We have a very good department, and then I get the phone. Well, in the report, they say if I can or I cannot, right? So it's the responsibility is the genetist, and the genetist is going to make my life easy because they say, okay, this mosaicism is not involving chromosome 21 or 13, as we said first. Second, this mosaicism, the percentage is low, it's fine, then you may transfer it. In the last place, but you can do it. So I will be very happy because I got the report, the paper with the genetist looking at the test is telling me what to do. Based on that, they know what chromosomes are involved, if it's danger, or there are the possibility of having an alive baby with a problem. So this will be discarded, and the percentage of mosaicism. So, and they'll give you can allow do that. It's not my responsibility in the end, but the genetist. Okay.
Of course. Thank you so much for that and confirming this. And how long does it take to get the result of non-invasive PGTA, right? So is it possible to do fresh transfer within the same cycle?
No, it's not possible to do the fresh cycles. We have to freeze the embryos. Yeah, no, because it may take a couple of weeks or so.
Okay.
The result, as it happens with the invasive one, it takes some time. So, but nowadays, we follow here, we almost freeze all embryos. I mean, we don't, it's a long time that we don't have an hyperstimulation syndrome. And we transfer all embryos. It's not a policy of freeze all, but almost. Only the low responder ones are transferred with fresh embryos. And also I tell them, well, we freeze in a very good way because we do it a lot. And then there is a 98% rate of survivance of embryos after defrosting them. And also, if you have 4 embryos, you're going to freeze 3 of them because we're going to transfer just 1. So yes, almost. And also, I should say that in a non-invasive PGTA, many times what we do is just the patient may decide. This is something else that I can tell to the audience. Any patient may have 4 embryos, for example, frozen. And they say, well, doctor, now I've changed my mind and I would like to check it with a non-invasive one. Fine. We're going to defrost the embryos, and 6 hours later, we're going to obtain cells or chromosomes for that medium and to freeze the embryos again, twice, and nothing happened, right? So this is a normal practice, and we can do it and do the biopsy on day 5 and 12 hours later to freeze the embryos again and to obtain chromosomes or DNA from the medium, all right?
Thank you so much indeed. Next question is in Spanish, but I think we can take a look at this, of course. So please have a look. I will not read it.
Yes, se pregunta por qué me pidieron en la clínica que me hiciera la prueba del cariotipo y me pregunta se pide. I will translate that to English in a minute.
Sure, thank you.
¿Se pide esta prueba para decidir cuál de las dos PGT hacer? ¿O adelanta algún dato? ¿Sería para hacer FIFISI con semen de donante? Right. Okay. She says that she wonders why I was asking my clinic to have a karyotype, the patient herself. And the question is, you demand this karyotype in the parents, in the couple, to decide which one to do? Well, it might be. Let's answer this first question, because I always ask to all people that comes to the clinic, I ask them to do the karyotype. It's not compulsory in Spain, but it's a recommendation, because then 0.8% of couples, and probably if infertile couple is higher, may have a defect in the chromosomes. Not a Down syndrome, but a little piece of chromosome, number 8, may be broken and inverted or change the place. Nothing happened to the patient, but then it comes with repeated miscarriages, failure of implantation, etc. If we don't ask that, the karyotype, at the beginning, then a few couples at the end of the year may point at me and say, doctor, why didn't you ask that? You are asking me the karyotype now that I've done 2 IVF, I spent a lot of money, my wife had 2 miscarriages. So we always have the karyotype. And if the karyotype is normal, fine. If it's abnormal, then the genetist will tell us, okay, she should do a invasive one, or this alteration is not very important and forget about it. So that is the first question, and may decide, if it's abnormal, to do an invasive one probably. I've answered the second question. Adelanta algún dato is advice, how can I say that? Is there any information given before starting IVF? Of course, they do. Sería para una FIFIC, sería por una FIFIC consent. It will be for an IVF with donor bank and PGT-A. Okay, that's her case, no? That is going to be with semen bank, and she's 42. Right. As she's 42, we said that one indication of invasive PGTA is the age, because it's quite, we will find aneuploid embryo quite often. So I would do the invasive one, but the karyotype may even tell that patient not to do PGTA, invasive one. It's a bit complicated. If we find an abnormal karyotype in somehow that she's 42, she's going to be low responder, very few eggs, very few embryos, and we are going to analyze a 42 years old eggs with all its defects, and also we find a karyotype, an abnormal karyotype, the chances of having a healthy one are going to be very slim, and probably it might be recommended not to go through this technique and to go to egg donation. So yes, I would ask for the karyotype, knowing that the karyotype is normal, and then to go through the IVF. I assume that she may have some certain, if not high number of eggs, a bit suboptimal, a good number, and then she will decide whether to analyze that with an invasive PGTA. This is a case for invasive one, not for non-invasive one. Nowadays, maybe in a few years' time, we are giving this speech saying that now there is 100% of concordance, and then we're going to forget about the invasive one, and we're doing non-invasive for everybody. But nowadays, has these limitations.
Thank you so much indeed. And there's a thanks from the patient herself right here. So thank you. Indeed, interesting question indeed as well. And let's have a look, probably our final question. So if you have more questions, you know what to do. This will be the final call. And the question, is what day of the culture you can start detecting DNA in the culture media? Very good.
Very good. They say that the best day is the day 6, is what we've been told. I mean that, you know, the blastocyst may reach the blastocyst stage in day 5, even day 6. We transfer in day 5 or day 6 anyway. So, and they say that in day 6 is better. We will find more chromosomes, more DNA in the culture system than in day 5. They recommend to go through day 6. Yeah.
Okay, thank you for the clarification to this question as well. As I mentioned, looks like that was our final question, but thank you so much, everyone, for all of those. It was, as I predicted, a very interesting session indeed, an interesting topic. Dr. Jose, thank you so much for joining us today. It's been great to have you back. And I'm really looking forward to some more events with you for sure. Anything else you wish to add before we finish for today?
No, nothing at all. I'm very happy that the only thing is that I like to see the face of the people I'm talking to, but I suppose that is not possible. But anyway, I hope that this speech has been useful, and that is the only thing I pretend. Okay, thank you very much.
Thank you so much indeed. Remember, it has been recorded. You will be able to find it on our website. It will be available there tomorrow. And of course, if you have any other questions, you can always get in touch with Dr. Jose Garcia and his team, and I'm sure they will be happy to help you out. And I just want to also add one more thing. Again, I just want to ask you if there are any questions. I mean, if there are any topics you wish for us to discuss, please type this in the chat or email email me at caroline@europeanfertilitysociety.com, and we'll be happy to address the topics that you are mostly interested in, so we can prepare those also for the next year, because as you know, we will be back for sure. So don't hesitate if you have anything that you wish to for us to discuss. Just email me. That will be, I guess, the best option. And you can also share your feedback after this webinar. There is a button for you to write something about our webinars. We've done more than 500 webinars already, so it's been a great team of experts like Dr. José García and his entire team at Vista Hermosa. There were plenty of doctors before with us as well, so if you would like to share any feedback, please do so. And also, lastly, I want to add that we will be back on Thursday, on 14th of December. We will discuss supplements and what you should consider during, before, and after IVF. So if this is a topic that you find interesting, join us. We will be live again, and I'm sure you will have lots of questions. So thank you, everyone, for today. Dr. Garcia, thank you so much again.
Good evening. Thank you.
Lovely to see you, and have a good evening. Take care, everyone. Bye.
Bye. Thank you.